You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tanya Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. And she's also the director of the Adult CAR T-cell therapy program for hematological malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, everyone. Again, I'm Tanya Jain, and we're going on with our season 2 of Myelofibrosis for Medscape In Discussion podcast. This is our episode 6, and we're very fortunate to have Dr. Naveen Pemmaraju for this discussion on a futuristic vision of myelofibrosis treatment landscape. Dr. Pemmaraju, we welcome you to the podcast.
Thanks, Dr. Jain, for having me.
Dr. Pemmaraju does not need any introduction, but quickly, Dr. Pemmaraju is a professor in the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston, Texas. He's also the inaugural director of the BPDCN, which is a blastic plasmacytoid dendritic cell neoplasm program, and is the executive director of cancer medicine for the MD Anderson Cancer Network. And we want to share the mic today with Dr. Pemmaraju, asking him about his vision for the future in myelofibrosis treatment landscape. We'll get started. Maybe let's start with where things are, and maybe you can share with us with your engagement in a lot of the protocol development and therapeutics development. What do you think, or which ones are your favorite developments in the field of MPNs in the recent past that you feel will stay around with us and we'll continue to hear more about them?
Oh, well, great. First of all, Dr. Jain, thanks for having me on. I think this series that you're doing is so great for all the stakeholders for MPN education. So I applaud you and the team. You know, I think this is an exciting era, an exciting time to talk about what you just mentioned. There's 3 or 4 hot topic areas that I would love for our patients, caregivers, practitioners, pharma, everybody to know about. One is in the early stage MPN. So in our polycythemia vera and ET, this is an area that really there hasn't been much drug development in over 20 to 30 years. And so I would lump them together as sort of before you get to myelofibrosis. There's some nice developments there. There's some new classes of drugs, actual real classes of drugs that are emerging that we didn't have 5-6 years ago. For example, the hepcidin modulators and mimetics in polycythemia vera, essentially trying to restore normalization of the distribution of iron in the body system so that folks don't have too high of a hematocrit. And so that class of drugs, my goodness, already has 4, potentially 5 or 6 drugs already in the clinic in either phase 1 or about to be. And then even in our ET, the essential thrombocytosis, some novel classes of drugs, including but not limited to LSD1 inhibitors, which can you believe are in phase 3 randomized frontline testing and trial. So for folks who think there haven't been much movement there, I would highlight that. And then in our myelofibrosis field, as you and I and others have discussed, a couple of things to keep your eye on. One is the development of JAK inhibitor plus another drug, which we'll talk all about. So combinations that build on the JAK inhibitor backbone. We've had several of these combinations make it all the way to phase 3 randomized frontline trials, some mixed results that we can talk about. So novel agent plus a JAK inhibitor. And then lastly, the development of improving anemia in the myelofibrosis. So I'm really happy to see some movement there. Again, drugs that may either modify the natural history of MF, therefore improving the anemia or going after the anemia alone. So I think those are some categories that are getting all of us really excited in the current era.
That's awesome. I think you highlight some of the major therapeutic advances that are happening. As you think about drug development, and much of that you have been involved in many of these things, and obviously we all applaud your work and your engagement there. But for all these drugs in development, as a clinician if you were your clinician only had, how would you see these being used in the future? Where do you see the field evolving, like in the next 10 to 15 years?
What a great question. And I think it's going to define a lot of what we do over the next decade. One, I would say that stem cell transplant remains the only curative modality for our MPNs in 2025. And I want to repeat that because it's something that you and others have really nicely shown us and pioneered. Stem cell transplant, allo transplant remains the only curative. So I actually envision still that we have an era where we still have stem cell transplant, but perhaps we're able to guide the patients earlier and quicker to transplant or potentially delay for the ones that it may not be as effective. And so what I mean by that is the high risk myelofibrosis patient. You have a young patient, let's say a 35-year-old patient, high risk molecular mutations. We're not curing them with these drugs alone. One hypothesis that I would put forward, and this is a futuristic platform, could it be over the next 5 to 10 years, we identify that super young but high risk patient who's fit enough to take, let's say, combination therapy, so a JAK inhibitor plus your best novel agent, and if I can borrow from the terminology, Dr. Jain, of multiple myeloma or acute myeloid leukemia, perhaps an induction, if you will, of X amount of time, your two best agents up front, debulk the disease, get it to its best response, and then from there, a branch point. Allo stem cell transplant, which of course has to be effective and decrease morbidity and mortality. Or if unable to go for transplant, then branch point to a more consolidation maintenance approach. Perhaps after you do, I don't know, 3 to 6 months, I'm just saying, then you get down to single agent rather than doing a sequential, let's see how it goes. And then by the time transplant comes around, you're neither too healthy nor too sick. So I put that in one paradigm. That's for the high risk patient who we know, you and I know, we can sense that that person's going to go to AML in a few years. Then I would say another bucket is for the patient with PV, for example. We've always said, oh, there's a low risk PV, Dr. Jain, that maybe doesn't need treatment. But then, my goodness, you have the 41-year-old who has a stroke or a heart attack. Maybe it's that we haven't had good enough treatments for those patients. And so, can you have a series of drugs, whether it's the interferon agents, JAK inhibitor, the hepcidin mimetics modulators, that can be either given as single agent or I know this is going to be paradigm shifting as a combination, a hepcidin mimetic plus something else. And again, modify the disease to the point where you don't ever have that first thrombotic event. That's what I'm envisioning. We're not there yet necessarily, mainly because of financial toxicity, medical complications and toxicity. But I wanted to put those kind of cutting edge concepts to you. What do you think, Dr. Jain?
Oh, that sounds phenomenal, and I love that idea. I love that approach. Thrombosis free in an early MPN.
Right.
I guess if I can repeat some of your words, optimizing patients better on their way to transplant,
That's it.
because all of us have shown that the better the disease control going into transplant, the better the outcome. So patients who are truly high risk and transplant is sort of inevitable can be optimized disease better from a spleen standpoint or in general health status, performance status standpoint, or even marrow fibrosis, which
Mm,
we've never looked into in much detail to see if transplant outcomes can be better. And the ones who are not high risk and don't need transplant, or transplant may not be as necessary right away, to be able to stall this or stall the disease progression for as further as we can. And certainly, data with interferons now is starting to guide us a little bit in that scope as well. So I love those ideas, and I totally hear you. And I think a lot of this credit goes to the improved diagnostics and wider
yes.
applicability of NGS panels and such. I'm sure you feel the same way, but every time we see that young patient with a splanchnic vein thrombosis and the liver consequences as a result, it breaks your heart. And I think that thrombosis component, where the efforts tend to be less focused when the disease seems low risk, which is why I do not like that terminology, because no
Right.
diagnosis is low risk. That would be a dream come true, right? Like we have a thrombosis free situation from Jack to sort of delving a little more into that. In terms of diagnostics, where do you think are the untapped areas?
Well, I love this question. We don't talk about it enough at our meetings. And so it's only a platform like this where you've given an opportunity. If we can be current, modern, and futuristic, I can identify three areas that are on my mind right now. So I love what you said. You're right. The next generation sequencing NGS, of course, for you and me is so common, so mandatory, but we know not everywhere has done that. But we do advocate for people to check beyond the big three, JAK2, MIPL, and CALR. So please do check TP53, ASXL1. A lot of these mutations are part of the modern scoring systems for high risk, determining transplant, maybe even determining clinical trial. But one area that is starting to pop up, we're using it here at MD Anderson, and I think we'll catch on in the next few years, is something called OGM, Dr. Jain, so optical genome mapping. It sounds futuristic and costly, and it sort of is both of those right now, but it's a way to kind of look beyond cytogenetics and molecular, and we are already in the first year or two of implementation seeing novel or at least cryptic fusions and other entities that we never picked up before. And this is also a way to pick up known entities that are a little bit harder to find, like your 8p11 syndrome, where you have an approved drug that you can give. So I think deeper and more elegant methods of finding these molecular and chromosomal abnormalities beyond what we have. Again, they always start out costly and inaccessible, and then over time. So I think that's one approach. Two, I think very important is colleagues to you and me that we've been following their work closely is that of, this is Royston, Adam Mead, the UK group. When they first started talking about this, my goodness, it was futuristic, but it is the development of AI and math modeling to take previously invasive methods of diagnosis and make it non-invasive. The easiest way that they've explained it to me and the way I can explain it to folks is some of the information we get from bone marrow fibrosis. You had mentioned that earlier. This is something phenomenal. Can we get to the point where without having to use needle, a bone marrow biopsy, that we can somehow monitor what's going on in the patient's system deeper than the blood and the blood smear? But I think this is something. So that would be 3D math modeling and AI. And of course, in the last just 1 year, 2 years, this seems to be quite a bit of reality where AI is so well developed compared to just 5 years ago. So the use of AI in our diagnostics, I predict, is not 100 years away. I think it's much sooner than that. And then the last thing I would say in diagnostics that I really have seen help us tremendously is the advent of, on the bone marrow biopsy itself, checking the flow cytometry and other adjunct tests rather than doing them at different time points. So on the bone marrow, if you can pull multiple pulls, as you said, so NGS, I would rate highest, but cytogenetics, flow cytometry, even this OGM I'm talking about. So multiple pulls on the same bone marrow biopsy. And then obviously pathologist reading, I think, is still important for morphology. For example, pre-fibrotic MF, Dr. Jain, versus ET and MF. So I would say improve methods at the level of the hematopathologist. Of course, that comes from expert training, interacting with us as clinicians. So I don't know, those are some of the things I see help. And I think it has not just academic implications. I would say the advent of the pre-fibrotic MF is something that just in our own last 5-10 years, you can identify a subset of patients, maybe a bit different from ET, not quite to myelofibrosis. The advent of checking ASXL1 TP53 early, watching for dynamic clonal evolution, including it in your MIP70 score, who's going to go to transplant earlier. And then remember, selecting clinical trials. If unfortunately a patient has relapsed refractory disease, we found a FLT3 mutation or an IDH mutation that may have an approved drug from somewhere else. So these are some of the applications I think are helping.
I think that makes a lot of sense. I'd love to continue to hear about the OMG platform. As we always say, the genomics are driving much of this, obviously with some external second impact as well. But the genomics are a big point, not just in diagnostics, but also therapeutic implications and progression and kind of all the decisions that we make around that. You and others have done a lot of work in therapeutic development in myelofibrosis. But I still always feel, and I hope I'm wrong, but I always feel that myelofibrosis tends to remain this rare blood malignancy, and everything reaches it the last, right? Like kind of like
Right.
this wicked stepchild of heme malignancies. In terms of therapeutics, we've seen sort of targeted agents develop in AML and other malignancies. We've seen venetoclax maybe finding some space in advanced MF, or at least being anecdotally used or more than anecdotally used. We've seen cellular therapy being developed in some of the other heme malignancies. What are your thoughts on the therapeutic development, outside of the drugs that are in the pipeline right now?
Yeah, as you know, as you said nicely, this is a passion area to me. I think this is so important that we can't discuss it enough, actually. So I love the question. Broad strokes first, I think that it is surprising to me, that's the word I would use, that we still have a monotherapy-based system as the backbone, particularly for these advanced patients with myelofibrosis. It's very surprising to me. Now, it's not because you, me, Ruben, and others haven't tried. We've tried. The problem has been with some of the early efforts, BCL-XL inhibition and bromodomain inhibition in particular. We made it all the way phase 3, positive primary data, which means spleen volume reduction was met, actually double that of ruxolitinib or JAK inhibitor alone. But we importantly, we did not meet the symptom burden expectation for improvement statistically. So point number one, and this is controversial, what I'm going to say, so I want to say that not everyone will agree with me, but I'm wondering out loud, can we move beyond spleen and symptoms as we move beyond JAK inhibitor monotherapy, where that system was developed, and either add, incorporate, or yes, potentially even replace with overall survival, progression-free survival, event-free survival, as our colleagues in AML, multiple myeloma, and others have done. This, I think, is a central concept, and I'll advocate that every day. Two, with the new, even the more novel agents that are coming in, PIM kinase, telomerase inhibition, XPO1, MDM2, all of these, which are actually in phase 2 to phase 3 testing, either as a novel agent by itself after JAK inhibitor, so sequential, or in combination with, I think it's important to include some of the mechanisms of action. Can you start to see cytokine improvement? Can you start to see biochemical evidence that the disease is working for its target? What about fibrosis reversal, as you nicely said in the earlier segment? So I wonder if we can have spleen and symptoms, fine, that's our backbone, OS, PFS, EFS, bridge to transplant, by the way, a very important successful marker your drug is working, and then a third layer of biochemical correlates that are not random. I'm not saying a random wish list here, but personalized to each drug. And then the Roman numeral 2 is allele clearance. We used to say, well, we're never going to see that. Well, guess what? Claire Harrison and JCO MAGIC study that you and I know well, showed for the very first time ruxolitinib at advanced PV, so not MF, but in PV, they showed that not only of the clearance of allele burden, but that correlated finally with OS, EFS, et cetera. And the EFS includes thrombosis-free interval, overall, all of these important endpoints. In myelofibrosis, we're starting to try to correlate these things, and we need to show that. And then finally, if I might add, another area is bridge to stem cell transplant. That's a huge success in this field. If you're not curing the disease, which we have not yet, right, with single agents or with double agents for that matter, as we were discussing earlier, can you at least get someone into a best response? And then because you're able to do that, bridge to transplant, that actually should be a success, not a failure that you, quote, came off the study. So what I'm calling for here, to say it directly, is as a field, we need to follow patients for the long term. We need to follow patients not just for 24 weeks, but for 5-7 years. We need to look at transplant as a part of the journey, not an end, and then you come off the study and, oh, we don't know what happened after that. And so the length of these studies, Dr. Jain, I think has been a big failure really for our field. Now, we know the realistic reason. It costs lots of money, resources, time, effort from both the patients and the providers. But if we can commit to that, have realistic correlatives, and have realistic endpoints, I think we could see a huge boon in drug development.
That's a phenomenal point. And as you said this, I was thinking about a post-transplant monitoring would mostly be like clinical outcomes monitoring. And I wonder if this is sort of an area and opportunity to partner with CIBMTR, for example, where this data is captured anyway, and perhaps something that companies or investigators can partner with to get that more long-term picture of what's happening with these patients long-term. Because it could be either way, right? It could be that these drugs are optimizing patients better for transplant and the transplant outcomes are better. And you're right, exactly. We don't know that because we're not looking at that. Or maybe there are drugs, God forbid, that are potentially detrimental to the outcome of transplant. And I think that's an important piece to be aware of as well, if that is happening at all, if that is at all of a concern.
And just to add to that, Dr. Jain, I would point the viewers to a couple of different studies in that realm. You yourself, so Dr. Tanya Jain, Johns Hopkins, you've published on this, exactly what we just said. So transplant outcomes, actually, and also you've also shown now immunotherapy as a new area of something to talk about. And then Dr. Nico Gagelman, our colleague, New England Journal, perhaps just 6 months ago, exactly what we're talking about. So mutational clearance post-transplant. These are the first efforts. Your efforts and his and maybe several others in the field sort of pre and post transplant monitoring and maintenance. I just love what you said, so I want to put that out there. That's an essential thing moving forward.
Well, you're kind to say that. I agree. I think Dr. Gagelsman work and their team's work, Dr. Kroger's and Dr. Gagelsman, I think has certainly helped advance the field. You brought up immunotherapies, and as you know, I can't let you go get away with that. But just mentioning that, uh, so maybe I'm going to have you maybe just spend a minute or two on where you think is the future of immunotherapy. We have CALR directed antibodies and BiTEs and JAK2 directed antibodies, sort of non-transplant immunotherapeutic options. Do you think they'll have a role in the MPN space?
Oh, that's great. I'm going to comment on those, but then I'm going to turn it back to you because you've given a phenomenal talk that I've seen now a couple times on some of these novel immunotherapeutic agents. But for the ones you asked about, the ones I'm involved in, I'm pretty excited about them. I think that the central tenet that I did not realize a few years ago is that since, and correct me if I'm wrong, but since CALR is, yes, it hangs out of the nucleus, but when it becomes mutated, it presents to the surface, therefore becoming susceptible to immune attack. That's changed our whole field. So version 1.0 was vaccines. So far, not yet a whole lot of clinical success, but let's see where that field goes. Version 2.0, monoclonal antibody and bispecifics, that's one we're a part of. So several of our sponsors that we've worked on for the more traditional TKIs have now moved into this field. Those phase 1s are ongoing and enrolling, so we hope to see data from them perhaps as early as the fall or winter in the conferences into next year. I think what's interesting there with CALR is you can attack it in any of the immune ways. So vaccine, monoclonal antibody, bispecific, even now CAR T is being developed by our colleagues in Europe, Alex Ramtos and Betsalia et al. So that's really phenomenally exciting. But what's exciting is how quick of a rapid from the preclinical observation to the clinical. So in the absence of clinical data, yes, I'm excited about the concept. Let's meet back in 6 to 12 months and see how it's going. JAK2, though, also, even though not directly immune susceptible, at least now we have ways of targeting the mutant clone itself rather than the pathway. And so there are the first 2 different drugs, either a mutant selective or mutant specific. But I've got to turn it back to you. You've given some nice updates on immunotherapeutics in the myeloid neoplasm. So I'd love to hear your update. You've got some cutting edge ones, Dr. Jain.
Well, I think you summarized it beautifully. Obviously, I'm biased around this, but I do think immunotherapy has been transforming in general in the oncological space. It's just taken some time to get to myelofibrosis, as you beautifully alluded to, the challenge with the targets. You may or may not know this, but the fact that the CALR is the most immunogenic is something that Ruben and I worked with Peter Cohen at Mayo Clinic, Arizona, back when I was a fellow.
Wow.
That project, as many other fellow projects, did not come to fruition. So it's not a published project, but we had some funding around it, and we collected a bunch of CALR patient samples to work on some of the peptide sequencing in Dr. Cohen's lab. This is something that's been of interest for a while, and I think it's been a joy to watch some of the novel ways to target CALR now being developing. I suspect we'll hear more at EHA and some of the other meetings. I don't know how much I can say right now, but we'll hear at some of the meetings upcoming as to what the data looks like and where the promise of these will be. In general, as you've mentioned, I mean, we've blocked pathways so far, and we've seen some suppression of disease or myelosuppression and cytoreduction. We haven't quite seen getting rid of the mutant clone, which eventually is what is needed with or without a transplant. My hope would be that these drugs can potentially get us there. Maybe not in version 1.0 as you mentioned, but maybe in version 6.0 or 3.0, or I don't know. We'll see. But I think at least it's getting there. At least we're thinking about it and investing time and money into it. So let me close this. I mean, this has been such an enlightening discussion. Maybe if we could close this by what is Dr. Naveen Pemaraju's dream treatment paradigm for myelofibrosis. If you had all your druthers, obviously, if you had all your druthers, nobody would have myelofibrosis. But the one after that, if you were to see someone with myelofibrosis, what would be that gratifying treatment approach in Dr. Pemaraju's dream world?
This has been fantastic. You promised me we'd be talking about futuristic things. So, the disclaimer here is, yeah, this is going to be some futuristic, cutting edge stuff I'm going to say, but let's put it out there. I think when you were mentioning earlier, it really stimulated something that I want to say, which is, can we hit this awful disease earlier before it's too late? You nicely said that because you also are one of the experts in our field that knows both MPN and transplant. And oftentimes we're sending our patients too late to transplant when the disease is too advanced or when the body is too sick. I'd like to put out there in this fun, important kind of intellectual conversation that I would say there's two areas where I didn't mention. One is CHIP. So CHIP is this clonal hematopoiesis indeterminate potential. Maybe we've known about it for a decade or so. I want to put out there that JAK2 is among the top 5 most common chips. My suspicion, at least we started to see that some of those JAK2 chips could possibly either transform to MPN, Dr. Jain, or maybe they already are a low-grade MPN because these patients have thrombotic events, cardiovascular events. So I don't know if the word is chemo prevention or early identification, but we're seeing CHIP clinics, your institution, mine, Sloan Kettering, all around the world starting to develop. But what I'd like to challenge the stakeholders, pharma, philanthropy, investigators, everybody is, can we start to develop actual targeted therapy at the level of CHIP, at least for JAK2 CHIP? I'm only talking about our MPN field, before it turns into MPN. That's one thing that could be a decade-long effort. Number two, as we mentioned, God, you said it beautifully, which is, I don't like the moniker of low risk because low risk, I think, just means we don't have treatments yet to treat, and the risk-benefit balance isn't there. So we really want to double down. The PV field is a good one for the testing field. The hepcidin mimetics modulators I've been part of, we're going to hear more about them in the summer and fall meetings. By themselves, they may not eradicate the disease clone for sure. They weren't designed to do that, perhaps make people phlebotomy-free, but either those in combination with other agents, or can we give them as solo agents to the previously thought of low risk, make someone phlebotomy-free, and we need to show this over time, then they can be thrombosis-free, cardiovascular event-free. So really my thoughts are on the earlier. And then in myelofibrosis, as we both said, can we get to the point where it's okay to treat the disease earlier upfront and attack it before the clones have a chance to escape? So again, could it be a combination therapy upfront, then followed by a more long-term consolidation maintenance? I'd like to see transplant moved up earlier and more often with all the great developments that are happening, post-transplant side, better everything, better supportive care. And then for that large chunk of patients who are truly, truly stem cell transplant ineligible, really, truly, can we do what you said earlier in the earlier segment, which is to give them a phenomenal therapy with minimal side effects? Because at the end of the day, our friend and mentor and colleague, Ruben Mesa, says it best, which is, can we have our patients live longer and live better, right? Those are the two things. And I think that's my dream paradigm. And I think we really are getting there. And I think that we're going to see a lot of developments in just the next 3 to 5 years.
What I'm hearing you say repeatedly is overall survival, overall survival,
Yes, you
overall
heard that,
survival.
right. You got it.
We want agents that will help us achieve that. And not just overall survival, I guess PROs or quality of life. So better overall survival, better quality of life.
That's it.
Well, Dr. Pemmaraju, this has been a fun discussion. And the evidence of that is that this is the longest podcast that we have recorded so far. And honestly, I could keep going and hearing from you all the wonderful things. This has been fun. And I hope our audience has enjoyed it as well, hearing about some of the early stage developments that Dr. Pemmaraju summarized with hepcidin mimetics, LSD inhibitors, and then in myelofibrosis combinations and how to use them maybe as an initial induction and kind of staying on a lesser aggressive treatment as maintenance. Obviously, I'm ever so grateful to Dr. Pemmaraju for putting a shout out for the role of transplant as well. Although I will say, if immunotherapy does the job, I'm happy to go open my coffee shop and not transplant. If there are better treatments, that is what we want ultimately. We'll be excited to hear about how your work with the OGM goes, the optical genome mapping. That sounds fantastic. And strategies to improving fibrosis, which we hear less about, but certainly important. There's so much to summarize, Dr. Pemmaraju, and I'm so thankful to you for bringing all of these things up and sharing your vision for the future today.
Thank you so much, Dr. Jain, for having me, and to your team. This was phenomenal. Thank you very much.
All right, wonderful. Right back at you. We'll sign off. Thank you very much.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tanya Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.